and share my screen. And we're going to jump right into it this morning, guys. Yesterday, when we left off, we were talking about hypertension. And I posted this and I posted a couple of different videos. Today, I'm going to post another video about the basically like the mechanism of action. What happens
You sure?
when you gotta
That's her.
whoever's
Let me see.
hold on. You gotta pause your mic or mute your mic for me. Okay, so let me fix this real quick. What did we just get in?
Financial.
Okay. All right. So what we're going to do is we're going to, we'll post a video that's going to show you the mechanism of action of what's happening inside when high blood pressure occurs. It's a really awesome video. I'd like everybody to check it out. But today we're going to talk about some more cardiovascular related conditions, and hypotension is one of them. And hypotension is defined as if your systolic is 90 or lower and your diastolic is 60 or lower. Now, this is hypertension. Now, what am I always telling you about? That could be somebody's normal. For me, this is my normal. I have very low blood pressure, but that's why I've got this here. So don't be alert, too worried if you do have people who come in whose blood pressure is a little bit low, okay? Now, it's the same thing with blood sugar. Some people might run in the 80s and be fine, but other people, they get lightheaded and feel dizzy and woozy. It's the same thing with like hypotension. It's all about if they are symptomatic and have these numbers. And the symptoms would be dizziness or lightheaded, fainting, which is, remember, syncope, a blurry vision, nausea, fatigue, or a lack of concentration, okay? This is when we'd be concerned about the patient being hypotensive. Any other time, it's not, if they're, the numbers are still decent and they are completely asymptomatic. It's something that normally the doctor's not going to be too concerned about. Causes of hypotension. Now we're talking about, numbers like 80 over 56, so really low, okay? This could be from infection, systemic, heart issues. This could also, very, very common, be related to endocrine. And when you think endocrine, I want you to think hypothyroidism. And a lot of times like Hashimoto's that we talked about, but thyroid disease can cause a hypotension. Blood loss, which makes sense. The more blood volume you lose, the lower your pressure is going to be. And of course, dehydration as well. The lower your fluid levels, your blood pressure is going to drop. A lack of vitamin B12 is also a cause of hypotension. This is partially one of the reasons mine is low is B12, and the other part, y'all are gonna think this is funny, but it was in not just like some thing you see scroll across your feed, but it was in an actual medical abstract with the American Journal of American Medicine or something like that, JAMA, whatever that is. And it said that women, especially, who have really large thighs, tend to be lower in blood pressure. And I have some big old thighs, so that and this might be one of the reasons. I've always had large thighs, so it might be one of the reasons. And I, the way the doctor explained it in the abstract is that because of blood flow and different things like that, it made sense. I'm probably making it sound silly, but it was an actual thing. So, what is the treatment that they would do with somebody for hypotension? Well, first thing the doctor is going to tell you is drink more water, get your fluid intake up higher. Now, if that doesn't work, then they may tell you add a little more salt or sodium to the diet. And if that still doesn't work, like, because when we get old, a lot of times we see this with our little old ladies because they do have some thyroid issues and maybe some heart issues. They'll tell them to wear a compression stocking. And that's when you see those little grannies with the tight little hose looking socks on. And that helps just keep the blood up and keeps the pressure in the what do we call the core higher. And then sometimes prescriptions are necessary if it gets too low. All right. The next thing we're gonna talk about is, I think it's the third leading cause of death in the United States, if I'm not mistaken. And the American Heart Association made a really, really big campaign a few years ago to try to get people to understand the seriousness of a stroke. And in the medical community and field, we're going to know that a stroke is actually a cerebrovascular accident, and we abbreviate that. The patient had a CVA. Okay, so now this CVA, I've also, it's been lumped in with aneurysms, thrombus, blood clots, different things like that. But what it means, and it makes sense because the definition is damage to the brain from interruption of its blood supply. And any of those things could do that. But what we need to know, and that's what I was telling you, I had a friend of our family, his mom was sitting 53 years old, sitting at the dinner table, eating dinner, and fell over. And she had a CVA, and they weren't able to, she wasn't able to recover. And her causes, they looked back as she'd been on birth control for a very long time, and she had been smoking since she was like 13 or 14, and a couple packs a day. And those two are deadly combo for women, like I was explaining. And because besides that, she was very healthy. So they think that was the cause of her CVA. Now, is a stroke an emergency? Absolutely. And this is where the American Heart Association came up with something. And they want you to think about this as FAST. And this acronym you need to remember, okay? Because when we think about how do we need to act if we see somebody having a heart attack, or how do we need to do if somebody's having a stroke? We need to act fast, right? But for this mnemonic, it's F is for face, okay? Because usually when somebody has a stroke, you might see a slight drooping or a drop of their facial muscles or expression or their mouth on one side. It's very common. A is for arm, or basically are they asymmetric? So what we see sometimes is whatever side the stroke, they won't be able to lift that arm, or they can't feel that side. right? So A is for arm weakness or paralysis or something abnormal. S is for speech. And so one of the other things that we see with CVAs is the patient, and a lot of times they'll try to speak, and that side of their face or the body that was affected, you'll notice that their mouth won't move on that side. Or when they try to, there's a part of the brain called the Wernicke, and if it's close to the area that was damaged, they won't be able to make comprehensive sentences. They won't be like ask them to say Mary had a little lamb, and they might be able to say it, but it's really slurred, or they get it jumbled. That's speech. If their speech starts sounding odd and weird and off, that's a big warning sign. And then T is for time, okay? So all of these together are how the um, American Heart Association wants you to think about when you see any of this. It's time to call 911 immediately, because time is of the essence here. If a patient is having a stroke and we can get them to the facility, some ambulances now are advanced, and they started this right after I got out of the 911 business, but they actually carry TPA. And you see that here. TPA is a type of medication, and it's basically like, think of your brain as um, a plumbing system. It is Drano for your clog. So if you had a clog up here, it's basically, it busts up that clot. And if we can get that in someone soon enough, we can minimize brain damage, and we can actually, even make their recovery time faster, and their long-term side effects of this stroke very minimal. But it's all about how fast we recognize and how fast we get the patient to medical care, okay? Um, and then the other thing is, the doctors always tell everyone, we know cigarette smoking is an absolute major cause of strokes. The carcinogenic chemicals and things that are in cigarettes do play a massive issue, not only on your lungs, but on the vascular system as well, especially in the brain. And then we know that, diet and keeping in shape and making sure you don't have high cholesterol and develop hardening of the arteries and that kind of stuff. Those all help reduce your chances of a stroke as well. Okay? Does anybody have questions about FAST before we move on, or strokes, CVAs?
No,
CVA
no.
is, I do.
Okay.
CVA stands,
For,
um,
for this, cerebral
oh,
vascular accident, right here.
okay, okay. That was all. Yeah,
That's okay.
thank you.
Mhm.
Right.
Anyone else? Okay. Then I'm going to go ahead and go on here. And then the next thing I want to talk about is um, thrombophlebitis. Okay. And thrombophlebitis is, this is the reason that I stopped letting students do IVs on me. And uh, back during when I used to teach paramedic, I actually developed a very mild thrombophlebitis in my left arm, and it was just because they think it was, they went in and they checked for blood clots and they checked for all of, thrombuses and all this stuff, and it wasn't. It was just inflammation of the vein, but it was scary for me because, like I told you, my children's father, my first husband, passed away from a thrombus, a PE. So I was just like, freaked out, with the symptoms. So, what thrombophlebitis is basically inflammation of the vein, okay? And it can cause pain, it can cause swelling, it can cause discomfort, and that's at its mild form. Fortunately, what I have, it is something that usually affects your lower limbs. We know, because we've studied DVT, deep vein thrombosis, right? And then that's and those are the people that we see who are sedentary for long periods of time, like your truck drivers and people on a plane or somebody traveling long distances, right? Those people are more prone, desk workers who set improperly. These people are people who are more prone to DVT. And the reason that we know a thrombus, so let's go back and revisit that. What was a thrombus? A thrombus is a fixed either blood clot, fat clot, or some type of plaque, right? And it means it's still attached. When it becomes deadly is if it breaks off, because once a thrombus breaks off, it then becomes a pulmonary, an embolus, and it can go into the lungs, it could go to the brain, it could go anywhere. All right, and an embolus is deadly if it gets to the lungs, the pulmonary system, or the heart, or the brain, right? So we prevent this by making sure if we take long trips, and I know I've mentioned this before, we take long trips, what are we going to do? We're going to try to get out at them rest stops and walk. And if you're driving long distances, moving that left foot, the one that normally doesn't move when you're driving. If you're on an airplane, making sure your feet are uncrossed, and if you can't get up to move to go to the restroom, or paddle your feet up and down underneath the seat, so something along the lines of keeping the blood flowing. All right, and these are the things that we know can be beneficial to our patients, or people who are susceptible to blood clots and so forth. So with just the basic, like thrombophlebitis, maybe they have the very mild, right? The treatment for this is usually elevating the site, picking up the legs, or putting up the arm, but like I said, it's most of the time it's legs, and putting, depending on what the doctor suggests, a warm or cold compress, and anti-inflammatory medications. And sometimes if they feel that this is due to because of maybe an infection, they'll give antibiotics as well. Okay. Now, we are finished with this, but there are some more things that I do want to go back and I want to cover. I know that we began talking about EKGs, and we started getting we dipped a little bit into it. But I'm going to go here. And I'm going to go ahead and pull this up. Because y'all didn't think we were done, did you? Y'all see it says, and I don't know if this is 50 in your book. This might be from my old school. But do y'all see my PowerPoint here with the Pearson's?
Yes.
Okay.
Yes.
All right. This video I'm going to post to Teams, and it's basically going to walk you through a little bit what we've talked about with EKG, okay? And then, of course, at the beginning, it tells you your chapter, the terms to learn, and you need to know the definitions of the words. You need to be able to explain the waves on an EKG. And remember, EKG is the same thing as an ECG. It's just if you're old school or not, depends on who taught you. Being able to understand the functioning of the machine itself, the leads, and to be able to properly place leads and properly be able to troubleshoot when something doesn't go correctly, all right? We know just because we finished this that coronary artery, or CAD, is one of the main reasons that people start developing arrhythmias or electrical complications as far as with the heart. And we know that a lot of times when we go to the doctor and the doctor says, okay, hey, you're here for your physical, let's get a baseline. Remember that term? A baseline EKG, because I see here you're 38, you're healthy, everything looks great. Let's get a picture of your heart right now. So when we follow up with that 10 years from now, how much has it changed, if at all, right? Sorry, 1 second. Hey Siri, set a timer for 2 hours.
Okay.
Blood sugar. Okay, so we're going to go over these things. We're going to go over your role as a medical assistant. Now, I've already talked to y'all about how the EKG came about, and that was the Ivan Thoven guy or whatever, and how he found out that placing the little electrodes and getting remember his pyramid, his triangle. His triangle was the fact that with these positive and negative electrodes, he could get a reading of the heart's electrical activity. And that's what we want to be able to understand and get a basic feel of. Nobody is going to expect you to be an expert. Nobody is going to expect you to read and interpret EKGs. That is not your job, okay? That is the doctor's job, okay? So I've had students who have gone and they were told, well, you should be able to read this. Yes, I was given EKG training, but I was not trained to interpret EKGs. That's that is the proper and correct way, without being rude or anything, that you let somebody know that, yes, I can hook them up and I can recognize severe abnormal rhythms, but it's, yeah, you know what I'm saying? Wave, when we talk about the movements on an EKG, we refer to those as waves. And remember, the straight line is our baseline. And when we measure And when we talk about the strength or the voltage, because every single wave we see on an EKG is from, sorry, cat issues, is from when their SA node and the AV node and all of them are sending out their electrical currents and making the waves of positive and negative electrical waves on the paper that we read. If there is no energy, if there's no electricity, right, the EKG is going to record a flat line, right? Because if there's nothing to pick up electricity wise, then there's nothing to record. And this is the isoelectric line, okay? Now, I know we've talked briefly on the last one about polarity, and I told you to dust off that part of high school where you learned about, cells, positive and positive and negative, and with their protons and electrons and everything. Don't worry, we're not going to get that in depth, okay? What we do and should understand is the basic, that the myocardium, the muscle, right? We know that there is electricity, and we know that in our heart we have those nodes, right? And who's the leader? The leader is the SA node, and he's the conductor that starts this electrical activity, and he's the one that maintains that 60 to 80 beats, right? He's the one that keeps the show flowing in a healthy, normal heart. And we also learned about the heart and its working phases and its resting phases. And this is kind of what this is going into, but it takes it a bit deeper. It talks about the cells and how they become polarized and a positive and negative charge. I don't want y'all to have to focus on that. It's not necessary for an MA to be able to have to go down to that level. If you do move on with your training, you will get to further into it. You will start learning about the polarity. You'll learn about the actual chemicals like your sodium and calcium and potassium and all those channels that actually are causing these changes to occur that stimulate that bring about the electrical currents, okay? And that's, if you think about it, that's why when I tell you, how many times have I told you, like, I think maybe it might have been in my other class, with pediatric patients, little kids don't walk around and have heart attacks. But do we see cardiac events in pediatric patients? Yes. And what is the main reason that we see? Dehydration. And what did I just say about calcium and potassium and sodium and all that? That's what runs the cells. And if you're dehydrated, are you getting those electrolytes that you need? No. So that's why when I have seen cardiac issues in small babies and that didn't have a birth defect or something, or children, it was because of severe dehydration, infection, those sort of things. And like I said, you can read back over this, and it talks about the resting and the polarization as far as the active and repolarization. You can go through this, but don't stress about it too much, okay? This is continuing with it. This is, y'all see this? It's weird. It's like they tried to shove everything. Let's make it a little smaller so we can try to see it here. They're trying to shove everything on one card. The main thing that I do want y'all to focus on, right, is this right here, the SA node. Remember, it's our pacemaker, and it controls the myocardial polarity, right? So the positive and the negatives. It's the one that initiates, remember the conductor, who initiates the electrical activity. And where was the SA node located? It's located in the right atrium. Yeah, and so it's up in the our right atrium, and it's, like I said, it's the lead node, and it talks about through here as the SA node initiates, starts its electrical activity, the atrial cells become depolarized, and the electrical impulses travel from the atria to the ventricle. And when this happens, the ventricles become depolarized. And like I said, don't worry, don't freak out with the whole polarization thing. Just remember, SA node stimulates the heart, okay? It starts the electrical chain that keeps our heart beating. Now, with that beating, we are producing electrical waves. And this is where we see our normal electric cardiac cycle. That is one heartbeat. Remember when I showed, and y'all can see this, right? My screen I pull up.
Yes.
Thank you, hon. So we're looking at this, right? But here's, when we break it down, we're right here, okay? This is a heartbeat. So when you, that's when I was telling you, you go back and look at this, that's 1, 2, 3, 4. So let's say that was their rhythm, their strip. That's how many beats? That's 40 beats, okay? Because each P, Q, R, S, T complex is a heartbeat, okay? And I actually really like, I'm going to save this. I really like that picture. You'll be seeing it again. But I want y'all to know that. And I want you to be able to understand that when we're looking, now see, this is, like I told you, this little mysterious U wave that people talk about, like I said, I've seen it because a doctor pointed it out to me. I'd never seen it really in the field, but it's there. It can be there. But this would be your normal. And do we see how our well, I'm getting advanced. I'm jumping ahead of myself. But remember how I was talking to y'all about that, let me go back to this QRS complex, right? This is the ventricles, all right? And we're going to remember that, okay? This is the contraction of the atria, okay? And then this is the repolarization, right? Or the downtime of the ventricles. And I'm gonna actually use this and make y'all a little cheat sheet with this, because this is excellent. So, and this is what this is talking about. Your PQRST, your normal heartbeat, consists of these. The P is atrial, the top, right? Atrial depolarization. The QRS is your ventricle depolarization. And then your T is your repolarization. And I know you're probably like, oh my God, I'm never gonna, it's okay, I promise. Pardon me. Now let's look at this, okay? Give us a refresher about where those nodes were. See, where's that at? Did anybody forget patients right, patients left? No, I know y'all didn't, because I hopefully drilled it into you. Remember, this is our patients right and our patients left, because we turn ourselves the way the patient's facing, okay? Don't get that confused. Guys, I cannot stress that enough. When you go to do your EKG placements, you always remember patients right, patients left. Okay, now here we go with our SA node. It's right up here, and then you see the AV, and then the bundle, and then we know the Purkinje fibers are down embedded in this area, right? And this right here is kind of like that picture I just saved. And I'm gonna, like I said, I'm gonna kind of break that picture down and make you a little cheat sheet to make it easier. But what this is saying is that the P wave right here, this corresponds directly with the contraction of the atria, okay? And then this QRS correlates to the ventricles contracting. And then here with the T represents the preparation for the next cycle. And this should be your relaxation phase, right? This is why, who remembers what I told you? If you saw an elevated ST or T wave that was real high, what was that a sign of? Anybody remember? Do the Jeopardy thing. No, nobody? It was a sign of could be a sign of an MI, right? Elevated ST is a very much something we would watch for and look for when we thought of a person maybe having a heart attack or have recently had a heart attack, okay? And then I'm probably going to stop. Let me check my time here. Yeah, I'm probably going to go ahead and stop here so we don't get to, I'm going to take my, let's turn off the recording.